Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land which is part of OCA's new pilot Male Partners program to support male partners of women diagnosed with ovarian cancer. This program has been informed by results of research indicating the unmet needs of male caregivers. I'd also like to thank Angela Jones from OCA for assisting in developing this webinar. This webinar will focus on the emotional impact of caring for a woman with ovarian cancer, including issues around sexuality and intimacy. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you do have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. And for technical assistance, please phone Redback Support on 1800 733 416. So I'm extremely privileged to introduce our presenters to you. Our first speaker is Dr. Oliver Holmes, a clinical psychologist at Peter McCallum Cancer Centre, who helps patients and families manage the psychological impacts of cancer. Dr. Holmes will discuss the emotional impact of caring for a woman with ovarian cancer, including anxiety, communication and relationship challenges, fear of recurrence, and the impact on sleep. Our second speaker is Kim Hobbs, an oncology social worker at the Westmead Centre for Gynaecological Cancer in Sydney, who has supported many women and couples as they negotiate the challenges imposed by an ovarian cancer diagnosis. Kim will discuss issues around intimacy and sexuality, including strategies for maintaining relationship wellbeing. And we'll also hear from Tom Brace, a 66-year-old Queensland magistrate, father of 4 and grandfather of 5, whose wife was diagnosed with stage 4 ovarian cancer in 2016. Tom will share his experiences of caring for his wife, including some of the challenges that he has faced. So now I'd like to hand over to our first speaker, Dr. Oliver Holmes. Thanks, Oliver.
Thanks, Vanessa. I'm really happy to be here. My name's Oliver. I work at Peter McCallum Cancer Centre in Melbourne. I'm going to talk about the psychological impacts of caring for women with ovarian cancer. I've met lots and lots of cancer patients and their families and loved ones, and I think it's really important to have some time to focus on the loved ones of people with cancer, as the challenges can be really immense. What I'd like to do tonight is go over some of the common psychological challenges that people can experience when they're caring for women with cancer. I'm going to pay particular attention to anxiety and depression and relationship challenges. And I want to talk a little bit about the impact of COVID on some of these challenges. And I think most importantly, I want to cover just some strategies that can help to improve these issues if they come up, and also protect against them coming up in the first place. A lot of the time, the people I meet who play really prominent caring roles, they don't always resonate with the term carer because they consider caring for their loved ones to just be a normal part of their relationship, something that needs to be done and that they're happy to do. There are formal caring roles that people do apply for, but when I'm talking about carers, I'm really just meaning anybody who plays a caring and supportive role for the one that they love. A lot of the time this is spouses or partners, but sometimes it can be children or other close relatives or friends or neighbours. This is just an example of some of the responsibilities that carers find themselves picking up when someone they love is diagnosed with ovarian cancer. The one on the right, just so you know, is the social challenges and responsibilities. So I think most obvious are the medical responsibilities that come up around caring for someone with a diagnosis. These can be really complicated and really full on, as a lot of you might already know. The medical appointments that are involved in cancer can be almost a full-time job. And a lot of the time these are negotiated around other jobs and commitments. So just carrying the burden of all of the different medical commitments can be really overwhelming. And carers often pick up a really important role in managing these things. And then around the medical challenges, there's the practical challenges of needing to adjust a household or a family to having someone's role really significantly changed. A lot of the time, the carers are needing to pick up a lot of extra responsibilities around the home. And a lot of the time, these aren't really ever overtly talked about. They're just sort of naturally evolving changes in the way the house runs. And often people doing things that they've never really practiced doing before in the house. There's lots of emotional responsibilities that carers pick up to support their loved ones, not just the person diagnosed with cancer, but the people in the broader family or social network. They can have to reassure people a lot of the time, act as a cheerleader. They have to keep a lot of people informed about what's going on a lot of the time, and that is also an emotional burden, because often it's the people who are delivering the news who then need to sort of carry the emotional burden from the person who's being informed about what's going on. So this is just a few examples of a huge variety of responsibilities that carers often pick up. Now, in the same way that that was just a list of possible responsibilities, this is just a list of possible emotional responses. So I guess the take-home message I would really want everybody to leave with from this slide is that there's really no normal emotional response to someone that you love being diagnosed with cancer. There is shock, there is anger, exhaustion. There's really often a lot of fear, and the fear can often be covered up by other emotions like feeling really overwhelmed or irritable. Most people who are diagnosed with cancer and most carers for people with cancer are really, really aware of the uncertainty that's been cast over their life, and that carries a huge emotional burden. I think that the other important thing is that these emotions that people go through as part of the cancer journey can come up at any time. From investigating medical issues to actually getting a diagnosis, to getting a treatment plan, to following through it with a treatment plan, having plans change all the time. At every step of the journey, there are different emotions that can come up in response to these, and there's just no normal response. I want to talk specifically about anxiety and depression, first of all, because I think these are quite common, and they also cover a really wide range of experiences that people can have when they get distressed. When I'm talking about anxiety, I'm talking about a set of embodied feelings and also cognitions and emotions, and also a set of behaviours that people tend to come up with. And so physically, when people start to feel anxious, they often feel tense or have shortness of breath. They can have sweatiness or shakiness. And a lot of the time when people are anxious, they feel pain, sometimes in their stomach, and they have nausea or stomach problems. I think one of the really central experiences of anxiety is worrying. And it's normal for people to worry, but when people start to feel really anxious, the worrying feels intrusive, and it feels like something that they can't actually stop doing. It can often involve a lot of feelings of fear and being full of dread or feeling overwhelmed. And people might compensate for some of these feelings by avoiding the things that are making them anxious, or taking an opposite track and getting really hypervigilant and looking for symptoms or looking for things that might be going wrong. So if anxiety is winding people up more and more and more, depression is bringing people down more and more. It often makes people have a lot of physical changes in their body. They might start to notice feeling much more sleepy or fatigued, or their appetite changing. They might notice changes in their sex drive. The thoughts that people have when they feel depressed are often quite scattered and muddled, or they find it difficult to concentrate. The thoughts can be really negative, but it's very often characterized by negative thoughts that are really critical of themselves, really full of guilt and self-blame. And a lot of the time, the behaviors that are associated with depression are to withdraw from other people or withdraw from activities that they otherwise would have enjoyed. And this is a real problem because it sort of creates a bit of a cycle where people will then miss out on things that they otherwise would have used to sort of cheer themselves up or make them feel a bit grounded. As I said before, carers pick up a huge amount of emotional and pragmatic burden when someone they love has cancer. And there are also, alongside all of those responsibilities that they pick up, there are just huge changes that happen within the relationship as well. So there can be a lot of changes to the roles that people tend to play within their relationships. And often, as I said before, these can kind of go unspoken. People are sort of just expecting themselves to make major adjustments to the kind of things that they would normally be responsible for day to day. And this can be really difficult, especially when they're things that someone's not used to doing. And because it's a lot of the time not spoken about, people can just expect themselves to perform just as well as they were normally performing in their life and in their relationship. There can often be resentment that comes up with this and tension in the relationship. And this is really difficult, especially because carers are, often really motivated by looking after the person they love. So when there is conflict, it can be really hard to acknowledge that. I think it's also really important to just acknowledge how challenging it is to take on a carer role where you're primarily wanting to help and support someone, but just feel exhausted or burned out and not up to the task sometimes. This is a really big burden that carers face, and it's really important to watch for anxiety and depression so people don't burn themselves out. And last year we had, and ongoing, we've had challenges of COVID, which have just absolutely magnified a lot of these risks because people are isolated and worried. That uncertainty that most cancer patients and most family members feel is magnified by the uncertainty of a whole society that doesn't really know what's going to happen next. And there is really magnified fears about the health of the people that we love. I think it's also really important to acknowledge that men who are caring for their loved ones face additional risks in that men are just taught a lot of the time to not seek support and not reach out for support, particularly about emotional needs. A lot of the men that I meet have been raised in their families and by society to be much more focused on solving problems and fixing problems rather than taking an emotional approach to managing their life and looking after their anxiety, looking after their depression. It's really discouraged a lot of the time for men in our culture. And so I think that acknowledging these barriers is also really important because when we do become emotionally burned out, then we're not really capable of looking after the people that we love. And so looking after one's emotions is really important. So a lot of the time, that sort of fixing the problem approach is really difficult too because cancer, and ovarian cancer in particular, presents a lot of problems that just can't be fixed. That's why I like this quote: you can't stop the waves from coming, but you can learn how to surf. And I want to just give you some really quick tips on how you might guard yourself against things like anxiety and depression and just correct them when they turn up. So when I talk about self-care, I'm talking about something that you really intentionally do, that you will make a commitment on a daily basis to do things that look after your own well-being. And the way that I like to frame this to people is to be able to make a plan to do at least one thing every day that feels like you've achieved something, and one thing every day that you genuinely enjoy doing. This is probably the first and foremost protective thing against depression. So we don't want people to neglect themselves. And I've put just some ideas of things that might be achievement and self-care and things that people might find enjoyable. I think that looking after your health is really important because a lot of the time when you're caring for someone with health problems, people will neglect their own health and well-being. So visiting a GP if there's something that you need to follow up on, getting exercise, making time to relax and wind down at the end of the day so that you can have a good night's sleep. And I think it's also important to acknowledge drug and alcohol use, because a lot of people can turn to these things to relax themselves, when it's quite healthy and good for our mood in the long run to make sure we have at least 1 or 2 days every week where we're alcohol and drug free. With anxiety, one of the really important things to do alongside those daily self-care practices is just be aware of the kind of thinking patterns that we have, and having a look for those moments where we're just ruminating over and over and over again about the same things that are stressing us out. These are some questions that you might ask yourself about the thoughts that you're having that are stressing you out. And the idea is just to try to bring in a bit of a balanced perspective about them. Some people find it really helpful to schedule some time to worry out loud, either writing or talking it through. And they find that if they do this purposefully, then they don't unintentionally ruminate about things later on. And another thing that you can do to break the pattern of worried rumination is to try and think of one action that you can take next about the problem that's going around and around in your head. And once you've got it, you can write it down and give yourself a reason to just stop going over it. If there's no action that you can take, that might be a sign that you can stop the rumination as well, because it's not actually helping. It may sound really weird. A lot of people find it really weird that I would suggest to schedule in times to have talks with your partner. But I think it's really important, because a lot of the time, especially in our closest relationships, we can spend heaps of time with somebody without actually airing the things out that we really feel like we need to talk about. Especially when caring for someone we love with cancer, it can feel almost guilty or inappropriate to bring up things that you might be having problems with in the relationship. But the longer that goes on, the more likely people are to feel burned out or resentful in the relationship. And so I think if you can schedule the right time to bring up the things that have been bothering you, there's much more chance in the long run you'll improve communication and well-being between you and your partner. And I also think that it's really important to schedule some time where cancer will not be the centre stage of the relationship, and people can do things without going over their medical needs, as hard as that might be sometimes. Very quickly, just want to acknowledge the role of grief in a lot of these things. I don't want to talk too much about anxiety and depression without talking about grief, because grief is an extremely natural response to loss. And I think that it's really important to keep in mind that grief is a huge part of coping with a diagnosis, because so many things are lost in that process. It's not just death, but also aspects of a relationship or future plans. And also grief can come up in a way that is anticipating a loss as well. It's really upsetting. And most of the time, the way grief works is that people need some time to focus on the loss, and then some time to do things that are called restoration orientated. It means that they're building their life up and adjusting to something new. And grief often works where people will bounce between these two different states, focusing on the loss and feeling the emotional distress of the loss, and then doing things that move their life forward. So I've given, I suppose, a really broad and surface level coverage of these things. And I would really encourage you to seek some support and get extra information if you feel like any of these things are relevant to you and you want some extra focus on them. You can do that by going and talking to a GP. There are excellent support groups available that you can look up. You might organise to see a psychologist, or if things feel really unmanageable to get out and go and organise those things, there are support lines that you can call up to speak with someone about it and make a bit of a plan. And that's my talk. Thanks very much. Happy to take a question if we do have time.
Thank you so much, Oliver, for providing us with all that valuable information. We do have one question from the audience. Can you give some advice around fixing sleep problems? Yeah, sure. Sleep problems are really, really common for people with a diagnosis and also people caring for them. And I suppose the first thing that I want to say in response to that is that they're really normal, and it's quite normal for people to have like little phases of their life where their sleep's disrupted. Over the long run, though, we want to have good behaviours that just tip our sleep in the right direction. I think probably the biggest
issue that I see with people is having expectations that they will be able to do really stimulating or stressful things and then just switch gears straight away and go to bed and go to sleep. Most of the work that I do to help people correct sleep problems is about them setting up a really nice routine where they can slowly wind down over time and do relaxing activities until they're ready to sleep. And for someone having sleep problems, I'd really recommend looking into some relaxation strategies like breathing strategies or muscle relaxation strategies that help people wind down much faster. And there are some good apps to help with that. Like I use the Calm app to help me when I want to wind down. I think a lot of people use Smiling Mind and things like that. So you can find some good apps to help with those relaxation strategies.
Great, thank you. Great advice. Thanks again, Oliver. We really appreciate your time.
Thanks very much.
I would now like to hand over to our second speaker, Kim Hobbs. Thanks, Kim.
Good evening, everyone. And like Oliver, it's a pleasure to be here and to be hooking up in this way that I think we can thank COVID for the technological advances we've made in getting a message out to a large number of people. I've never met Oliver, and we've certainly never compared notes on these presentations, but I am relieved to tell you that we're singing from the same song sheet, and it's sort of a relief to be the second speaker and to know that you're going to say things that are absolutely in accordance with the person who's gone before. So I'm going to focus a little bit more on relationships and intimacy and sexuality because they're important and they're a legitimate aspect of everyone's life, because we all have a sexual identity. We may not all be sexually active at any one time or any given time in our lives, but we are all sexual beings. And what the literature in oncology tells us is that health professionals are very bad at addressing sexuality and intimacy. And women and their partners tell us that they'd like much more information and support about these aspects of their relationship. So if we look at the literature, sexuality and intimacy concerns are frequently reported as unmet needs by couples. You and your partner probably feel uncomfortable raising sexuality concerns with health professionals. What on earth will they think of me? They're trying to save my wife's life or my partner's life with her cancer. I have no place asking about our sexual relationship. But I'm here to tell you that the healthcare professionals probably feel just as uncomfortable about having that discussion with you. But if we can start these awkward conversations, if we can start to communicate, we can improve sexual function and satisfaction, really usually just by providing some information and some fairly simple strategies. We'll talk towards the end about what to do when you need more than the simple strategies, but for most couples, simple strategies will get things back on track. And we know that sexual and intimate practices can be adapted to accommodate the many changes that happen while you go through cancer treatment. So we're really looking at how you adapt to change, because once you heard the words ovarian cancer, you were physically and emotionally assaulted. The changes are huge. Some of them are permanent changes, some are temporary, but none of the changes that have happened to you are unwanted, they're all unwelcome, and they're beyond your control. And it's really difficult and stressful to adapt to change. But a cancer diagnosis, although it takes away so much, and you know this, you know that the person who's being treated loses a lot of independence, therefore so do you. You can lose or reduce employment. Financial security is a problem frequently. Your future plans are just non-existent now, and it's difficult to make more plans. Bodily changes happen. If you've got a stoma or an ugly scar or indwelling venous access devices, and it takes away hope. But what we want to do is not to focus on the things that it takes away, but to look for some strategies to embrace change and find ways for opportunities for growth. Not the way that you would have chosen to improve yourself, but the cancer itself is unchangeable and it's chaotic. But what is it that we can maintain and control and enhance? And the answer to that question is the things that are in our control are relationships, intimacy, and sexuality. So for this purpose, for this presentation, it's a broad definition that I'm taking of sexuality and intimacy. It includes sexual behaviour, sensual activity, and emotional intimacy. So it's not just about whether or not you can achieve penetrative intercourse. Sexual anxieties and problems are common in the general population. We generally don't talk about them, but over the course of most people's lives, there will be some times at which sexual problems arise. They're expected and they're normal. And unfortunately, once they become entrenched, there's distress in relationships, persistent dysfunction, and then the whole intimate relationship can be lost. But there is good news, and that is that some form of sexual expression is always possible if you and your partner desire that. What are the impacts of cancer treatment on sexuality? Not just ovarian cancer treatment, any cancer. There's the direct impact. So there are changes to your physical functioning, there's changes to your interest in sex and your partner's interest in sex. There's things like pain and nausea and menopause. There's indirect impact, so changes in hormone productions, the fatigue that comes for you and for your partner with exhausting treatments, the side effects of treatment, and if you're worried about finances and about care of your children and how your adolescents are responding to this new stress in their lives, then you're not going to be very focused on your sexual function. The emotional impact, I won't go over that too much. That's really what Oliver's been talking about. But it can be compounded in ovarian cancer by changes to your fertility plans, by body image changes, and fears in you or in your partner about maybe transmitting the cancer. That's not a rational fear, but it's certainly one that we hear a lot about causing pain or causing recurrence. Again, no evidence for that, but it's just, if we talk with people on their own, then they will tell us that these are some of the worries that they have. And if you had a pre-existing problem in your intimate relationship, well, the cancer isn't going to make it any better. So we all have changes with sexual function over time. That happens with the evolution of the relationship, with things that happen with age-related changes that affect sexual functioning, limited information on education or education on anatomy and sexual functioning, which you would hope might be improving with this current millennial generation, but in some of the younger couples that I see, I don't think it is. But then, let's take a broader view. You and your partner may have other health problems. There might be diabetes or vascular disease, impotence, erectile dysfunction. Maybe there's age-related changes where it's more difficult to maintain sexual function. Most drugs, which include prescription medications and alcohol, are not good for sexual function. Your spiritual, cultural and religious beliefs come into this, as well as environmental factors. If the in-laws have had to move into the spare room to help you with managing the kids and the housework, then that's not very good for your intimate relationship either. If your level of sexual education and your knowledge and skills weren't terribly good before the cancer, then this is a real opportunity to do some learning. All medications can affect and usually negatively affect sexual functioning. So if you or your partner are using narcotic analgesics, if either of you are using hormone drugs, the oral contraceptives, antidepressants, antipsychotics, sedatives, just about anything you can think of, including the chemotherapy itself and the recreational drugs, can make sexual function decline. So what's changed for you? And think about this, we're obviously not going to ask you to tell us this, but what's changed for you? The common things that I hear is that both the women with ovarian cancer and their partners have a decreased libido. And that can happen during treatment, and that might be okay for a short amount of time. But what are you going to do when the treatment's finished and you're wanting to restore some normality, when you're wanting to take some control over the things that you can control in your life? One of the things that happens with couples, not just with cancer, but a fairly common problem, is desire discrepancy. So mismatched libido, where one person is not as interested in sexual behaviour as the other. Talk about it. If sexual intercourse isn't any longer going to be possible for a short period of time or for a longer period of time, then what else is there in your intimate relationship that you can give and receive pleasure? And then if there are changes in physical appearance, in your fertility plans, in your menopausal symptoms or low mood, then life is going to be quite difficult in trying to get your sexual relationship back on track. So we know that cancer treatments almost always have a negative impact on cancer, on sexuality and intimacy. So you should expect the worst, but don't accept it. What are the things that are still good in your relationship? Not just the things that are different, but what are the things that brought you together in the first place and that are still there that you can rekindle now? So the commonest problem in sexual function is poor communication. We might not be very good at telling each other what it is that we want to do in terms of increasing the range of intimate activities that are pleasurable for us and for our partners. Have a conversation with your partner. What's changed for her? She probably feels like she's not the person she used to be and that you see her differently. And no matter how much you can tell someone who's lost their hair and who has a large abdominal scar and maybe some lymphedema and perhaps a colostomy, that you think they're just the same person that you've always loved, that may not be the way she sees herself, and that's okay. Maybe your values and your priorities and your attitudes have changed. How you saw your future is different. Maybe you or she feels really disconnected with others, that although there are a lot of people around you offering support, you feel alone in the crowd. The woman with cancer will often feel that very vulnerable, disappointed in herself and in her body, and have some really understandable body image and self-esteem issues. And she needs to hear that they are validated, that it's okay to feel bad about the way that you look. And that will create uncertainty in relationships and sexuality and intimacy. But this is a webinar about you, and I think that we're not very good as health professionals in really teasing out what are the specific needs of partners, because we see them often, and you may see yourselves as care providers, rather than people in need of support yourselves. You're probably protective of your partner, and you may feel reluctant or even embarrassed to disclose that you have needs of your own. There is an inevitable increase in the physical and psychological burden of caring for someone with cancer. In fact, in the literature, you partners have been called second-order patients with levels of distress and anxiety and depression around about the same as the person being treated for cancer. And it is simply exhausting being a cheer squad. You may not have good formal and informal support. The people who are around you may feel reluctant to talk to you about what's happening in your life for fear of upsetting you. You need to be the one who reaches out and tells people what it is that you need. You may have health problems of your own. If this is the first encounter with the healthcare system, it's pretty overwhelming and very difficult to understand. Who are all these people who look after your wife? What is a registrar? What's a clinical trial? How do we get from one institution to another? Where can I go to get assistance about these things? And there are probably a lot of myths and misconceptions and stigma, particularly when it comes to sexuality. But if you feel burdened, and you may also feel guilty because you're not the one who's having cancer treatment, and why should you feel that bad? And the bottom line is that you're fearful about what the future holds. So in terms of your sexual and intimate functioning, what are your worries? Are you worried about causing pain or about being seen to be demanding? These are questions you need to ask your partner. Is there a lack of flexibility in negotiating sexual changes to adapt to the physical changes that have happened? Or are you still assuming that your sexual relationship will go on as it has over the years of your relationship? It may be that you actually feel less physically attracted to your changed partner, and you need to work on that to overcome your expressions of affection and intimacy. And roles do change during and after treatment, so there's a lack of private and enjoyable time together. and probably deep down a grief and fear about whether the illness will progress. So, I've said that we can take control and we can change things. So the first thing is to get out of that thinking that sex is not just penetrative intercourse. There are other sexual practices that you can think about. Be creative. Go back to your courting days. Look at intimacy and non-genital touching. Seek information about using aids that you might need to address some changes. So you might need to use vibrators or lubricant or dilators. And perhaps you need to acknowledge that your underlying relationship is the issue. And if that's the problem, then you need to now seek counselling, couple counselling, to address these concerns. But communication is the most important step. So like Oliver said, schedule some activities. Spontaneity has gone, probably, at least for now. So what else can you do? Some relaxation, some massage, music, dinner for two, different positions. Look at body image, ways to enhance body image so that you're covering up stomas and scars and hair loss. Find out what aids you can use, whether they be medications or hormonal treatments or lubricants. If pain is an issue, then time your pain relief medications so that sex can happen when your partner is more comfortable. So it might not be the end of the day as you fall into bed after a long and busy day at work now. It may be at different times when you've organised to have the children taken away for a weekend or booked yourselves into a hotel for a nice night together. Do you need a specialist sex therapist? Probably not, but a small number of couples will need referral to specialist services. So if you had pre-existing sexual difficulties or relationship difficulties, if you or your partner have a history of sexual abuse or other psychological issues, this is a prime time when they might just bubble to the surface. If you or your partner had a sexual disorder, or simply if you feel more comfortable talking about your sexual problems with a specialist service that isn't available or not associated with your ongoing cancer treatment. So a small number of people will need referral to a specialist sex therapist, and you can get that by asking either your GP or your specialist. So this can be a time for positive adjustments. If you can conquer relationship changes by living through this traumatic experience, then what you might find is a renewed appreciation for life and a hope for the future. Closer, not more distant, intimate relationships. New perspectives about your future directions together. Increased personal strength and resilience, but as I said before, not the ideal way to build your character. And improved lifestyles and behaviours. Always remember, the brain is our biggest sexual organ, so address the thoughts and the cognitions and the myths and misconceptions. The greatest barriers to good sexual functioning are anxiety, ignorance and misinformation. Intimate relationships can be maintained and even improved. Don't suffer in silence. Your care from the cancer health professionals should incorporate permission to address sexuality throughout all stages of treatment and recovery. It's a valid issue for all people, no matter how old you are, what your gender is, what your sexual preference is, or relationship status or health status. If you can communicate and adapt sexual practices to accommodate treatment-related changes, then you can keep a partner sexually satisfied. So the take-home message from me is accept the enormity of the ovarian cancer diagnosis. Give yourself some latitude. Set realistic tasks and goals for sexual recovery. Seek out and accept offers of help, but expect some setbacks along the way and roll with the punches. And congratulate yourself when you achieve small gains. So that's it from me. Back to you, Vanessa.
Thank you so much, Kim, for that extremely informative presentation on a topic, like you said, that is often very difficult to talk about. We just have one question. How do I begin to talk to my partner about my intimacy concerns without appearing to be heartless and insensitive?
this was the best lesson I ever learned. It was when I was quite a few years ago now, and I was talking to a group face-to-face actually of couples with ovarian cancer. And we talked about how there are all sorts of changes that needed to be accommodated when you have treatment for cancer, but don't let sexuality go and make sure you keep addressing it. And we talked about most of the things that we've talked about in this presentation. And one gentleman said to me, "You've overlooked something, Kim." He said, "I just think I would be inconsiderate to expect my wife to be having sex with me after all that she's been going through." This was a couple in their 60s. She started to cry and she said, "All this time, I thought you didn't find me attractive anymore." And so I would say that if it's in your head, if you're thinking, how can we get back to where we were before with our intimacy, then ask that question. This woman wasn't asking the question because she thought she was undesirable. He wasn't asking the question because he thought he was being inconsiderate. And so it's a difficult conversation to have with the health professionals, but can also be a difficult conversation to have with your partner.
Absolutely. I guess it all comes down to communication, doesn't it?
Yep.
Very, very important.
Which is what Oliver said as well.
Yeah.
Bit of a common theme.
Thanks. Absolutely. Thanks so much again, Kim, for joining us on this webinar. I really appreciate your time. I'd now like to hand over to our final speaker, Tom Brace. Thanks, Tom.
Thank you, Vanessa. I appreciate the opportunity to speak about my experience. As you said previously, my name's Tom Brace. I live in Mareeba, which is in far north Queensland, with my wife, who was diagnosed in April of 2016 at the age of 60 with stage 4 advanced ovarian cancer. People speak about the fear of recurrence. We've not had that, as we've not had remission. Ours has been one long period of treatments with some small breaks of a few months between treatment regimes. Treatments have included chemotherapy, surgery, a drug trial, and a number of alternative treatments. First up, my wife and I agreed she was not going to be a victim. That is, sit around with a poor fellow me attitude. We would do what we could to beat the disease. When it comes to emotions, I'm certainly not a medical professional. I don't know what the recognised emotions are, so I'm only speaking from my own experience and general knowledge. Whatever your entry into the club, you may have been told early on, as we were, you have ovarian cancer, there is no cure. Maybe you didn't take in much more of the consultation. Your brain and emotions were already in overdrive. Since then, your emotions have been fluctuating up and down for no apparent reason, or because something that has been said or happened. To be clear again, I'm not a psychologist. I can only speak from my own experience. So, like me, you may have experienced fear of the unknown, of the future. We attended a cancer retreat at the Gawler Foundation a couple of months after my wife's diagnosis. In a group session, we were asked about our fears. I responded with the fear of being alone. We've now been married almost 45 years. I don't want to reinvent myself to find a different life. I want this one to continue. After 5 years of living experience, I think I've come to grips with this, but it's not something I look forward to. I live in hope that advances in medicine will allow us to live out our lives together. You may, of course, experience anger at the doctors, at the world, because your partner should have been diagnosed earlier. You will find a common theme throughout what I say, and that is that you don't have to handle these emotions on your own. Accept help. You may have experienced frustration and confusion at not knowing what's coming next. What should I do? What does this mean? How will it affect us? And at the apparent loss of control of your lives, which now revolve around doctors and treatments. Also, frustration at the medical staff, who do a wonderful job, show compassion and genuinely care for you, but who sometimes seem to forget that you do have a life, that you may live outside the CBD, and yes, although you can be there at that time, at that place, You have to arrange time off work, flights, accommodation. You don't just live down the street. Seems that some receptionists think that you might. You may, of course, experienced anxiety and worry, the biggest negative emotion of all, it seems to me. It will drive you into the ground if you let it. I found that if you embrace the services available to you through the Cancer Council, or I believe Ovarian Cancer Australia, or your employment, or privately, you can manage anxiety. My motto has been for many years, since an earlier traumatic period in our lives, to live in day-tight compartments. The load of yesterday, added to that of tomorrow, carried today, is enough to make the strongest falter. I found this in the book by Dale Carnegie, How to Stop Worrying and Start Living. I credit this book with saving my life when I was in a very dark place. Of course, we will have experienced sorrow. As I say, don't adopt a victim mentality. It would be unusual not to feel sad given the circumstances. I don't believe there's anything wrong with wearing your emotions on your sleeve. If you feel sad or you are sad, be sad. Or if you cry, cry. But don't become consumed by it, and don't be afraid to seek professional help. I have found that talking to the psychologist is very beneficial. Something that I suffered, and you may have experienced, is bouts of spontaneous crying. Well, it happens. It may be in the shower or wherever. The brain must just turn over the emotions and bang, it happens. Also, it can happen when the most caring person asks you how your partner's going. The lip can curl, the eyes can water, and you can't answer. You might just have to walk away or put the phone down or dry your eyes and compose yourself. Horses for courses. I've always been very honest with people, maybe too much so. It would be easy just to say, she's doing well, or she's having treatment. But I find myself being more informative, which is maybe a mistake. Again, it depends on you and the circumstances, how you handle these encounters. I think Oliver mentioned this, and I certainly found it extremely difficult, and that is anticipatory grief. This did take a few years to appear for me, or at least until I understood what it was. It is real. You are not living in day-tight compartments, and you're grieving something you think is going to happen. A couple of hours with a psychologist assisted me on that front. You may or may not have thought about suicide. As sad as this sounds, you might find yourself with suicidal ideation, that is, suicidal thoughts. This might be an extreme emotion response to the upside-down world you have been thrown into, but I've got no doubt the pressure male partners endure could lead to these thoughts. You'd not be thought of badly if you were to experience this. But again, help is there. Don't be a rock. Seek help. If you've not already sought any help from Ovarian Cancer Australia, or maybe your psychologist, consider opening a line of communication. Do it early. Break the ice. Even do it regularly. So if you encounter a dark despair, you have someone to relate to. Lifeline is always there on 13 11 14. Put that number in your phone with other supports like your GP, Ovarian Cancer Australia, and your psychologist. Sometimes we hear people talking about, and I don't know whether it's an emotion, but what I call the why me emotion. Well, to be blunt, why not me? Around 1,500 women in Australia are diagnosed every year with this disease. The more you hang around hospitals and doctors' rooms, the more you start to wonder how you in fact escaped any illness yourself. It seems everybody has it. I've never had a why me attitude to this or anything else. It seems like such a futile exercise. We're in this boat, unfortunately. Better row it as best we can. Now, Kim spoke extensively about sexuality. This obviously can be a real issue. I don't think there is a one-size-fits-all. How you react sexually will depend on a range of influences. But remember, your partner has a serious gynaecological disease. She's been thrown a curveball. She's receiving potent poisonous chemical treatments. which sap her of energy. She's just getting over the last lot of treatment, starting to feel normal, and then it's time to start the next round of treatment. She may have had major surgery, which might have meant the removal of her female organs. Intercourse may well be painful for her. Intimacy may be physically possible, but would not be hard to imagine that a woman's desire might wane. Age may be relevant. You may have a similar experience. Your age, anxiety, fear, etc. may also mean your desire for intimacy wanes. No doubt this is easy to handle if both of you are feeling the same. If this is an issue for you, I could simply say, speak to one another. Speak to your psychologist. Be mindful and respectful of your partner's situation. Try to introduce things that are enjoyable, so you're still enjoying one another's company and love. Going to the movies, the beach, introducing other activities instead of just falling into the routine of doctors, hospital and home. In our case, we might stay in Cairns overnight, generally the night before treatment. We might also go and sit on the beach, or we might introduce a detour. On one occasion, we had an appointment to see the specialist in Brisbane. We went via Perth and the Indian Pacific. A bit of an extravagance perhaps, but we created memories which we now enjoy instead of just a trip to the doctor in Brisbane. There are other matters which I might touch upon. Your role as a male partner. From where I sit, I think my role is to support my wife. That's a very broad statement and encompasses all sorts of considerations. I don't know if you'd use the word rock. It's more than that. You have to blend into the new reality, accept the situation, and work within the parameters of your new world. You may take on more of the household duties. You may take on medical administration role, making sure appointments are kept, travel forms obtained, prescriptions kept filled. While I say this, you should not usurp your partner's independence. She should also try to maintain a sense of normality, especially when it comes to family and friendship groups. Obviously, this can all be a day-to-day proposition depending on her strength and wellness. We've been lucky, the oncologist says. You are clinically well. It's just that you have extensive disease progression. My wife has, as far as possible, which has probably only been about half her usual commitment, continued her involvement with our Lions Club, her Pictionary group, the Mahjong group, the ukulele group, yoga, swimming, and various alternative treatment programs. A lot depends on attitude. Keep a positive mental attitude. Stay calm. Have no care for the morrow. Well, that's all easier said than done, isn't it? How the hell can I maintain a positive attitude when I'm dealing with this illness? Take on more of the household duties, maintaining an income? It's hard, but try to prioritise. Do the things that have to be done. And if you can't, they'll have to wait until tomorrow. The other attitude is defeatist. You may have people or seen people who just adopt the I am defeated type of attitude and let their will fall apart. I can't be critical of that, and it is explainable. But it is possible, with the help of friends, family, and of course the psychologist, to maintain a healthier attitude, something of an acceptance with a commitment to give it all you can. We, of course, depend entirely on the medical profession. There are many outside influences that impact your emotions. Doctors may be one. They are good, they are bad, they care, they don't care, and so on. Overall, I think we're very lucky. As I've mentioned before, one of the recurring things is that doctors and medical staff don't seem to think that you still have a private life, and also that it has a time frame and schedule. Something which we discussed very early in the piece, probably because of my background, was estate planning. When we attended the Gawler Foundation Cancer Retreat in the Yarra Valley, we had a number of sessions, joint sessions. There were plenty of uncomfortable things to talk about, such as living and dying, but it's a reality. There are things you need to be considering: your wills, enduring power of attorney, or an advanced health directive, which might in some states, I think, be called a living will. You need to discuss these things while you both have capacity. Do it now. What your partner prefers when it comes to, do you know what your partner prefers when it comes to burial? Does she want to be cremated, buried in the lawn cemetery, flowers or not? As hard as it may be, it will give your partner peace of mind to know that her affairs will be organised and dealt with in the way that she would prefer. And it will save you the anguish of making these decisions when, very suddenly, being asked by a funeral director, what is to be done? As we grew older, we were dropping or reducing our various insurance covers. I was actually doing this around the time that my wife was diagnosed when I realised we had an old trauma cover. I checked, I made a claim. I thought it'd be like pulling teeth to get anything out of the insurer. But to my surprise, once I had the GP and the specialist complete a form, the money was in our bank account within a week. So if you've not, it may pay to check any old policies you have. And of course, your partner may have life insurance within superannuation. It may pay to check that as well. My wife and I discussed whether I should retire when she was diagnosed. We decided I should not. In hindsight, that was for us clearly the correct decision. It has meant that we've had a secure income and I've had a lot of support with time off. I've also benefited from staff supports in the form of free psychology sessions. And now I am ready to retire and will do so later this year. In Queensland, we have the Queensland Cancer Council, which was for us a good first port of call. Obviously, Ovarian Cancer Australia is a source of support and advice. If you are unsure or a bit lost, just contact the cancer councils in your state and explain what you're feeling and ask them for direction. These supports may be extremely important if you find you're drinking uncontrollably, dabbling in illicit substances, or gambling. The last thing you want is to lose your driver's license because you had some stupid binge drink. It may sound like a broken record, but if you find you're hitting the bottle more than is healthy for your relationship, then you should get help. Vanessa, back to you.
Wow, thank you so much, Tom, for being so open and honest and sharing your experiences caring for your wife. I know everyone watching will have been inspired, by your incredibly positive attitude. So thank you very much. We do have a couple of questions. The first one, what was your wife's CA125 when she was diagnosed, and how has it moved since then?
The dreaded CA125 marker. There's also a CA15.3 and other markers, but the one that we probably hear about most is the CA125. I don't know why, maybe because there's nothing available to measure the progress or otherwise of the disease other than scans, but we become hooked on the CA125 mark results every time there's a blood test. In my wife's case, when she was diagnosed, her CA125 mark was about 4,000. It has been going up steadily ever since, except for when she had surgery, it dropped, but it's currently somewhere over 14,000. You may feel elated when there's a reduction in the level and devastated when there's an increase. I think at times become too dependent on this test result, suffering a fair degree of anxiety waiting for the results. And then subsequently, when the results have shown an increase, but now after 5 years, although we're aware of the effect on us, we still want to know. Although now my wife only asks to be in for that CA125 marker to be included about once a month when we see the specialist instead of what was every week when she was having chemo. The other thing it seems to me is there's not a lot of uniformity of scale. I've heard of women being told by the doctor that a very low reading was a real concern. Whereas, as I say, my wife's kicked off at 4,000 and is now around 14,000. So all I can say about that is try not to become obsessed with it. I think it should be given its own syndrome, frankly.
Good tip, Tom. Thanks. There's one more question. I know we're running out of time, but I think it's a good question. What alternative treatments have you pursued? And would you recommend that we consider treatments beyond the mainstream treatments offered?
Pawpaw leaves, eating your own poo. There are many alternatives out there. You just have to look for them. My advice is that you need to really rely on and work with your specialists. In our case, we've pursued alternatives since day one, but always after discussing with our oncologist. We don't want our actions to be at odds with the primary medical treatment. I don't think that we've ever had any encouragement, just a bit of a sigh, a roll in the eyes, and maybe you're wasting your money. But the things that we have pursued is intravenous nutrient therapy, which is essentially large doses of vitamin C, magnesium and zinc, massage, colonics, which is washing out of the colon, enemas, meditation, lots of, diet, acupuncture, hyperbaric treatment, hypothermia treatment, supplements, naturopathy, and overseas treatments. In 2019, I think, yes, 2019, we went to Japan twice to see Dr. Teranuma Hiroshi in Japan, where my wife underwent a series of immunotherapy treatments where her blood was taken, enhanced, and then given back to her. But they're the sorts of alternative treatments which we have pursued. The difficulty with them is, of course, we don't know whether any of them work. There's no way to measure these things. But if we hadn't pursued those things, then perhaps she wouldn't have survived the 5 years as she has done. Vanessa?
Definitely something to think about. Thank you, Tom. And wow, what a journey you've been on. It's incredible. We wish you all the best. Thank you so much again for your time. And like I said, just for being so open and honest in sharing your experiences. There are no more questions, so we will leave it there. Once again, I'd just like to say a big thank you to our speakers, Dr. Oliver Holmes, Kim Hobbs and Tom Brace, for giving up their time and sharing so openly and willingly this evening. Before I conclude, I'd like to mention that we are commencing a monthly support session for male partners of women with ovarian cancer, which provides a safe space for men experiencing similar circumstances just to share and learn from each other. These sessions will be held online, so via Zoom, and our first session will be on the 21st of April at 7 p.m. To express your interest or for more information, you can email Angela at the address on your screen. And if you have any other questions, you can always give us a call at OCA, our information and support line on 1300 660 334. Thank you everyone for being on this webinar. We really hope that you found it valuable. In the next couple of days, you will receive an email with a link to the recording. Someone did ask, can they access the webinar? Yes, you can. So you will receive a link to the recording. You'll also receive an evaluation survey. If you don't mind just spending a couple of minutes to complete that for us, that just helps us to plan and develop future webinars. And the recording of this webinar will also be posted on the OCA website in the next couple of weeks. So thank you again, everyone. We do hope to see you for our next webinar in a few months' time. Enjoy your evening. Goodbye.